Everybody, I'm back with another video review. I'm AJ again. This is going to be the lower limb. I'm going to be on PowerPoint and I'm going to be using this laser pointer. I hope it doesn't bother you. More so, I hope you don't have any cats around because I don't think your computer would survive this lecture if I'm waving this around and a cat is attacking your computer. Anyway, first I would like to make a shout out to Dr. Jack Stern for the material in this PowerPoint as well as for teaching me the last year, and Josh B for creating the idea of video review sessions, and as well for some of the material that you're going to be seeing in this PowerPoint. I just want to go over what we are going to cover in this lecture. First, anatomical movements of the lower limb, because it's a bit different than the upper limb, and I'll explain myself when we get to it. The overview of the lumbosacral plexus, what the nerves are coming off of it, where they're coming from, where they're going, what they're innervating. Compartmentalizing the lower limb, I think, is very helpful, not only for identifying muscles of certain compartments, but where they are attaching and what they're doing. To continue innervations and actions of those muscles, cutaneous distribution of the skin of the lower limb, and then something called genu valgum, which I'm sure you guys have heard about, but I'm going to cover as well in this lecture. And then we're going to get into some clinical issues by Julia Michaels, just on repeat in the background while I'm talking about disorders of gait. Not really. Okay, so let's get started. Okay, so I've realized that from slide to slide my voice is sort of changing volumes, and so I apologize if I am screaming to you at one side and whispering in another, but we're just going to roll with it. Hopefully it keeps you on your toes and your cat entertained. I don't even know if you have a cat, but speaking of cats, where is my laser pointer? There we go. Okay, so if your computer is still intact, we're going to continue. First, I want to start with abduction and adduction because it's very similar, and by very similar I mean exactly the same as the upper limb. Abduction is going to be away from midline, and adduction is going to be toward midline. Okay, moving on. Flexion and extension is a bit different, so to give you a hint, flexion and extension we want to think of as making angles with the limb to the torso or wherever the joint is. So if we are going to be flexing the thigh, the upper portion of the lower limb, to the torso, we are decreasing the angle of those in comparison. Whereas if you're going to extend the thigh back to a 180 degree, you're bringing it, you're increasing the angle of the two, even such that you hyperextend, which is perfectly normal, the thigh into a wind up if you're going to kick someone, or let's go with something, then you would have a greater than 180, and that would be extension. And then the action of kicking would be flexion, where you're bringing the angle less than 180. Okay, I think you get it. So let's move on to flexion and extension of the knee. Flexion of the knee is going to be decreasing the angle of the lower half of the leg to the thigh, and extension of the knee is going to be bringing it back to 180, and again, you can't go past 180 because that would be hyperextending the knee and you'd be doing some damage. Okay, dorsiflexion and plantar flexion is a bit confusing, but just realize that the dorsum, just like the hand, is sort of the back side, the extensor side of the foot, whereas plantar side is the base, the bottom of your foot. So dorsiflexion is going to be decreasing the angle from your foot to the lower part of your leg, whereas plantar flexion is basically extension of the foot, and I've seen it called extension, but plantar flexion, I believe, is a bit more proper. Anyway, moving on, we have a bit of rotation in the ankle where we get some inversion towards midline and eversion away from midline, and you'll see which muscle groups do that in the later slides. So you're probably thinking, what the flip? I thought of flexion as anterior motion of the biceps, and now you're telling me it's a posterior motion of the hamstring muscles. Well, let me try and explain why it's such in the next slide. Okay, so first we're going to talk about our ancestors, which were four-legged, somewhat amphibious creatures. We are going to take a cross-section of their leg and we're going to see how it fares with evolution. And we're going to convince ourselves that the more ventral muscle group that we see here is not going to be as ventral in bipedal organisms such as ourselves. So let's take this cross section and we're going to name the ventral muscle group blue, the dorsal muscle group orange, and we're going to rotate it in plane 90 degrees around this axis. And you're going to see it makes this weird looking limb, and we've seen the rotation of the muscle groups respectively, but we're not done there because that doesn't look anything like our lower limb. We're going to rotate it once more in the opposite out of plane axis, and now it's sort of, we can convince ourselves that this looks like our knee, this looks like our foot, and this looks like our lower limb. And let's follow what the muscle groups did. So we had a ventral muscle group, blue, that sort of went posterior in the lower limb in bipedal organisms, and a dorsal one that went anterior and lateral in these muscle groups. Okay, so ventral, posterior, and medial, dorsal, anterior, and lateral. And if flexion and extension are going to swap from upper limb to lower limb, that means a lot more is going to flop as well, and we're going to get into that in the lumbosacral plexus. Okay, so to appreciate the rotation of the lower limb in development and in evolution, we can also see this in the lumbosacral plexus nerves. So we divide up the four major innervators of the muscles of the lower limb into two ventral and two dorsal, orange and blue. Go Syracuse. The more dorsal are going to be more posterior, yet those are going to innervate the more anterior and lateral structures. And the anterior, more ventral blue roots, or nerves actually, are going to innervate the posterior and medial compartments of the legs. So we have this four compartment system, whereas in the upper limb we had a two compartment system. So just realize that. What's similar to the lumbosacral plexus in comparison to the brachial plexus is that the more superior roots are going to supply proximal muscles, and inferior roots are going to supply distal muscles. Okay, so with that being said, let's start naming some of these. So before you freak out, I just want to point out that the more superior nerves that we see here are actually things that we've seen in the abdominal and pelvic cavities. So we won't really have to worry about those because we already know what they do, right? Right? Someone say right. Bueller? Bueller? Oh, okay. Anyway, let's continue on. So we already talked about the four and sort of what they do. We'll get more into detail later. But we see the lateral femoral cutaneous, which is coming off the lumbosacral plexus, L2 and L3. That's going to do, obviously, the lateral cutaneous skin. We also see some muscle fibers more in the sacral plexus. We see superior gluteal nerve, inferior gluteal nerve, nerve to quadratus femoris, nerve to obturator internus, as well as a couple of piriformis nerves. And we're going to talk about what those do in the next slide. Also realize that we have a posterior femoral cutaneous coming off the sacral plexus, but we don't see that in this drawing. Okay, so more superior, more proximal, more inferior, more distal, and posterior coming off the lumbosacral plexus, more dorsal, are actually going to do anterior because it's flipped because of that rotation. Okay, we don't have to worry about, drawing it out or labeling everything because there's really not that many. We just have to worry about these four, the femoral, the obturator, the common peroneal, and the tibial. Okay, quick note on the tibial and common peroneal. They come together to form this common epineurium sheath, and we are going to consider that the sciatic nerve, even though the sciatic nerve doesn't really exist. It's just composed of tibial and common peroneal, which are going to innervate muscles respectively. Okay? All right. Okay, so let's talk about some of those branches of the lumbosacral plexus that weren't part of the Fantastic Four. The gluteal region is where you're going to find most of those. So the superior gluteal nerve is going to innervate the gluteus medius, gluteus minimus, and tensor fascia lata. Those aim to stabilize the pelvis and abduct the thigh. You can see medius and minimus here. Tensor fascia lata is going to be more lateral. It's not shown here. Those are going to abduct the thigh, and you can kind of see where they're inserting on the femur, the proximal head of the femur. Um, those, we were to tense those, we can kind of convince ourselves that the femur would abduct with the tensor fascia lata, and stabilize the pelvis. If we were to put the weight on the other side of the pelvis, um, tensing these muscles would be advantageous because it would keep the pelvis level. If we were to add weight or to collapse the pelvis, these muscles are really good at keeping it level, and we'll see this in disorders of gait later, when something goes wrong with the superior gluteal nerve. The inferior gluteal nerve just innervates the gluteus maximus. Um, that also stabilizes pelvis to a lesser extent, but the gluteus maximus also extends the thigh. It is going to cover all of these muscles, and insert lower down on the femur. And if we are going to act in this vector, we can convince ourselves that it would bring the femur back towards us, um, out of the computer towards you, extension of the thigh. The nerve to obturator internus obviously does obturator internus. It's going to laterally rotate the thigh. I really don't have too much more to say about that. The nerve to quadratus femoris is going to do the same thing, innervate the quadratus femoris and laterally rotate the thigh. And the lateral femoral cutaneous and posterior femoral cutaneous are going to do the anterior lateral and posterior sensory for the skin, and those are coming off of the lumbosacral plexus as well. Okay, all right, moving on. Okay, so we're just going to go over the four compartments of the thigh first. Realize first that obviously there's four compartments, not two, as we saw in the upper limb, and each compartment is given a nerve for the innervation of that group of muscles. So anterior is femoral, so let's start there. The femoral nerve is going to innervate this group of muscles: the iliopsoas, pectineus, sartorius, rectus femoris, vastus lateralis, intermedius, medialis, and articularis genu. Those are all going to sort of work together to flex the thigh, again, to decrease the angle between the thigh and the torso, and extend the knee to an extent. Each muscle does something different, but as a group, they do most of flexing the thigh and extending the knee. Okay, moving on to the lateral compartment. I don't know why all of them showed up at once, but the common peroneal does the lateral compartment. That's going to flex the knee because it's just going to innervate the short head of biceps femoris. Not much going on with the common peroneal because it's going to bifurcate and do more distal structures, which we'll get to shortly. Medial compartment is innervated by the obturator nerve. It's going to split very quickly from its origin into anterior and posterior obturator nerve. The posterior obturator nerve is going to do the obturator externus and the pubofemoral adductor adductor magnus, whereas the anterior obturator nerve is going to do the adductor brevis, adductor longus, and the gracilis, and those are going to work together to adduct the thigh and medially rotate as well, because if you're adducting the thigh, you also have a component of medial rotation. Okay, the posterior, done by the tibial nerve, comprises of the long head of biceps femoris, the semitendinosus, semimembranosus, and the ischiocondylar part of the adductor magnus. These are going to work together to extend the thigh, decrease the angle between torso and thigh, and flex the knee. I mean, increase the angle, I'm sorry, more 180 from torso to the leg. Okay, all right, so let's move on. Okay, in the lower part of the leg, past the knee, distal to the knee, we see something that jumps out at us already, and that's the fact that there's three compartments of the leg, and the fourth compartment is kind of occupied by the tibia, which is most anterior and medial, and you can kind of feel that and appreciate that if you just reach down and touch your leg. Also, if you've ever gotten kicked in the shin, that hurts pretty badly. That's because your tibia is really close to the surface of the skin. There's really no soft tissue that's covering it. So the three are anterior, lateral, and posterior compartments of the leg. At this point, the common peroneal nerve has split into deep peroneal and superficial peroneal nerves. The deep peroneal nerve is going to serve the anterior compartment, and that's going to do dorsiflexion, inversion, and extension of the toes. Tibialis anterior is going to do most dorsiflexion and inversion, extensor digitorum longus and extensor hallucis longus are going to do extension of the toes. And again, realize that extension is in the anterior compartment, but in the upper limb, the anterior compartment was composed of flexors. And again, because of that rotation of the limb. Proneus tertius is a less important muscle, but we'll see it in dissection, and that's going to invert the foot. Moving on, just to go back really quickly, hallucis longus. Hallucis just means big toe, just like pollicis in the hand meant thumb. Hallucis means big toe. Big toe. Superficial peroneal nerve is going to do proneus longus and proneus brevis, which are going to evert the foot. Posteriorly, you obviously have your calf muscles and your triceps surae, all innervated by your tibial nerve. Those are your gastrocnemius, your soleus, your plantaris, popliteus, tibialis posterior, flexor digitorum longus, flexor hallucis longus. Those are going to flex and plantar flex. Okay, so moving on to the foot, we only have two nerves that make it all the way down to the foot, the deep peroneal nerve, which is located in the dorsum, and it's not going to do much, and then we have the tibial nerve, which is located in the sole, which is responsible for the majority of the muscles in the foot, just like the median nerve was responsible for the majority of the muscles in the hand. So on the dorsum side, we have extensors, the extensor digitorum brevis and hallucis brevis. Those are going to be innervated by deep peroneal, and they extend the toes, obviously. On the dorsum, the sole side, we have a whole group of them. The abductor hallucis, I mean, we could read them off, but you can read them yourselves. Some words that we haven't seen before. Digiti quinti just means little toe. That should say quinti. And then we have interossei muscles, just like in the hand, that are going to abduct and adduct the toes. Quadratus plantae that we'll see, as well as some lumbricals, just like in the hand. So don't worry about those. We'll study their action and insertion and origin in lab, but just know that those are all innervated by the tibial nerve in the sole of the foot as we go along. To touch on the cutaneous distribution of nerves, coming from the lumbosacral plexus, we have the anterior cutaneous branch of the femoral nerve, which is going to do the entirety of the anterior aspect of the lower limb, the lateral femorocutaneous, which we saw coming off of the lumbosacral plexus on its own, which is going to do the upper thigh laterally. The posterior surface, we have the posterior femoral cutaneous nerve, which we saw coming off the sacral plexus, and then we have what makes up the sciatic sensory branches doing the lower limb and the lateral side of them. The obturator sends a sensory branch just to the spare spot halfway down the thigh itself, and then the common peroneal does the lateral half of the lower leg. Also, just realize that the tibial nerve sends branches all the way down into the sole of the foot, which makes sense because we just saw innervating muscles there. And just to go over a few, because this is important for herniated disc, this can send pain all the way down to the foot, and you can tell which level it's coming from depending on which disc is herniated based off of the symptoms that they're complaining of. If they're complaining of medial pain in the sole of the foot, you know that that's coming from the medial plantar nerve, and it's probably an L4, L5 herniated disc impinging on L5. Whereas if you have more lateral symptoms, or even in the heel, you know it's coming from L5, S1, either in the lateral plantar nerve or the medial calcaneal branches of S1 and S2. All right, so this is a little bit less important to know, but just realize that it's there, and we might see some of the branches bolded in lab. Now moving on to what I consider some fun stuff, and not just reading things to you guys. There's something called genu valgum in the leg and in bipedal organisms, aka just us. And what it means is the black line is the pull of the quadriceps femoris muscle, which isn't necessarily straight up and down. It's actually in the line of the femur. And this is a problem because it attaches to the patella. And the inferior attachment of the patella is the patellar ligament, which is just going straight down. So if you have a downward vector and this sort of diagonal vector from quadriceps femoris, you're going to have the tendency of the patellar bone to be dislocated or dislodged laterally, which this blue vector is showing. And that's just because of the pull of the quadriceps femoris. So to prevent that, we have two mechanisms in place as humans, and those are as follows. A separate muscle unique to humans called the VMO, the vastus medialis obliquus, and that is just pulling in the medial superior direction, part of the quadriceps almost, to keep that patella in place. And we have a lateral lip of the patellar groove in the distal articulation of the femur that is just a bit bigger than the medial groove, which helps keep that patella in place and doesn't allow it to displace laterally. It's called the lateral lip of the patellar groove in the femur. So that keeps our patella intact, and we can maintain our center of balance in a position that allows us to walk upright and not on all fours, which is pretty cool in my opinion. Okay, so I promised Julia Michaels, so there she is, but let's get rid of her. And now we're going to talk about some clinical issues that we come upon in studying these nerves. So here's one obvious gait disorder. But before we go through all of the disorders of the gait, let's talk about what gait is and what is normal gait. Not this. This is not normal gait. Okay, so even though this isn't the most high-yield aspect of your exam, I think it's really important to learn just because it encompasses everything that we've learned so far as all the nerves go and muscles and what they do, and it puts it into a clinical correlate, which is very useful when we have a patient with a lesion or an injury and we need to diagnose which nerve is involved. Okay, so let's talk about normal gait. So if we follow the right foot of this little figure, we're going to go through one cycle, which is broken up into two phases. So starting with the right foot heel strike is when it's on the ground, the heel just strikes the ground. You're going to move your weight forward, and then it's going to end support phase with a toe off, where you bring your right foot off of the ground and swing it forward. So that's the initiation of the swing phase, and which ends at the another heel strike. So from right foot heel strike, support phase where you're supporting on the right side, toe off where you're swinging the right side, to another heel strike creates one cycle of walking, and that's just going to repeat itself left, right, left, right, left, right. But what you can do is you can attach an electrode to an individual muscle, and you can see exactly when it is active during this cycle. So for the lesser gluteals, for example, the lesser gluteals are going to be active during the support phase just at heel strike, but not completely all the way to toe off, and then not at all during heel strike. And you can continue on, etc., to see when exactly the muscles are active. And we're going to do this for some of the disorders in gait. I guess you could say I'm walking you through some of the disorders of gait to add insult to injury. But let's go through and see what exactly happens when one of these muscle groups are paralyzed or one of the nerves are paralyzed. So let's start with the lesser gluteals. They are innervated by the superior gluteal nerve. I can't say that properly, I don't know why. The gluteus medius and the gluteus minimus are stabilizing the pelvis and abducting the thigh. So again, we talked about how it's important to keep the pelvis level when we're walking. And when the superior gluteal nerve is injured, we actually see the pelvis is not level. So when you are on the left side and the left superior gluteal nerve is injured, the right contralateral side is going to collapse because the weight is no longer even throughout the pelvis because your left superior gluteals are not abducting the thigh. So you're going to get a contralateral dip in your shoulder and the dipping of your contralateral side of the pelvis. And this is what it's going to look like when it's uncompensated. So to compensate and to avoid that problem and to avoid collapse of the entire pelvis, the patient, is going to intentionally lean to the left in order to keep their center of gravity right on the left side, the left leg, so that their hips do not collapse to the right. And that's compensated Trendelenburg gait, or a positive Trendelenburg sign, such that the hip collapses or they have this compensation pattern. The causes of this are rare. It's because of misplaced injections into the buttocks. So if you're going to get some steroids injected into your butt, just make sure to advise them properly now that you've gone through this prestigious anatomy course. It could also be caused by fracture of the pelvis and nearby tumors. So just to give you a heads up with these disorders, it's easy to think about them if you just know the nerve that's affected, the muscle that they innervate, and the action of that muscle. So the symptoms are just going to be the inability to do that action, also known as unopposed opposite action, right? So if, in this case, if we have the gluteus maximus, which extends the thigh, and that's done by the inferior gluteal nerve. If the inferior gluteal nerve is injured or transected for some reason, we would have an inability to extend the thigh, aka we would fall into flexion when we took a step on that side. This is called jackknifing, and so that's considered the jackknife gait. So when we take a step on the right side and the right inferior gluteal nerve is damaged, we are going to jackknife forward, aka flex forward, because we cannot extend the thigh to stay upright in proper posture. To compensate for that, the patient is going to be leaning backwards, particularly so when they step on the affected side. So if the right inferior gluteal nerve is affected, they're going to lean backwards during the right heel strike in order to keep their gravity in center over that, their weight over that right leg, so they don't have to flex or extend at the hip. They are just going to stay awkwardly straight, but it keeps them from face planting on the concrete, which is good. The causes of this, again, are very rare and mostly are just seen due to improper injection technique. So take note. The next one is the hamstrings. These are semitendinosus, semimembranosus, and biceps femoris. Long head, because again, the short head is common peroneal. The tibial nerve is the nerve that innervates the hamstrings. And again, we're looking at like the sciatic level. It's going to extend the thigh and flex the knee. And basically what's going to happen is going to be similar to the jackknifing gait, because if it's going to extend the thigh, and the inability to extend the thigh is just going to throw that person into jackknife gait just as well. The causes are a little bit different just because it's a different nerve. In the sciatic region, it's going to be fractures, dislocations of the hip surgery, sitting for too long on a wedged toilet seat, my Game of Thrones throne, if you will. The emaciated patients laying supine on an operating table for too long, they can, compress their sciatic nerve. And bicycling, prolonged sitting on a thick wallet, which is not my problem. Cello playing, tumors, and injections. Again, careful with the injections, people, okay? You can also get wounds in the thigh, which could technically sever the tibial nerve and give you the jackknife gait. Vasti muscle group, innervated by femoral nerve. The vastus medialis, vastus intermedius, and vastus lateralis are going to flex the thigh and extend the knee. So if we cannot extend the knee, then we're going to have a problem when we have a heel strike and all of our weight is being put onto that limb. If we cannot extend the knee, basically the knee is going to buckle into flexion if we cannot extend it. So what happens when you have a femoral nerve injury and you cannot extend your knee out during heel strike and support yourself and to prevent that buckling of the knee, patients are going to compensate by leaning forward and keeping their center of gravity such that they don't have to extend their knee, and also they might support their knee so that it doesn't buckle in on itself, which might have happened to them in the past because of this injury. And you can see exactly where it's working, again, just after heel strike when they need to prevent the buckling of the knee. This could be caused by hip surgeries, groin surgeries, retractors, applying pressure to psoas major, particularly in pelvic surgery, prolonged lithotomy positioning, um, a nerve compressed against the ankle and the ligament. Injuries to the groin, anterior hip dislocations, tumors, abscesses, fractures. You're also going to see, because it's such a big group, you're going to see muscle wasting, which just means the muscles are going to basically dwindle into very, very thin muscles. And you'll notice it's very weak in that area, just on one side. And you're going to see sensory loss as well with this femoral nerve injury. Okay, just two more. The triceps surae, which is gastrocnemius, and soleus, innervated by tibial nerve. That's going to plantar flex and flex the toes, but really causes the problem is the inability to plantar flex. So just during the support phase, plantar flexion is really important when you're starting to push off with your toe. So going into toe off and you're starting to prevent too much dorsiflexion, you give plantar flexion in order to propel yourself forward. So if you cannot plantar flex, if it's paralyzed, you cannot plant your foot because it's just going to collapse into dorsiflexion. So imagine you set your foot down and all of a sudden you dorsiflex way too much because you can't apply that pressure to toe off. So these people are going to have shortened support phases. They're going to have shortened steps because they can't bring their foot all the way back here because they cannot toe off properly. They're going to have no weight distribution behind the torso, um, and they are going to they're not going to be able to tiptoe, so they can't be sneaky, as I call it. Fractures or dislocations of the knee are going to cause this. Wounds to the popliteal fossa, as well as Baker's cysts, which are just herniated synovial membranes, which are shown here in the popliteal fossa as well. Okay, so now we have the anterior tibial muscles, which include tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius, or tertius, I call it tertius. But those are innervated by the common deep peroneal nerve. Those dorsiflex, invert the foot, and extend the toes. Most importantly for gait, you're going to look at dorsiflexion during the gait. Again, at heel strike, you dorsiflex a bit to get that heel down. At toe off, you're going to be dorsiflexing in order to swing your foot and keep it off the ground. And then again, to get another heel down, you have to dorsiflex again. So it's pretty common for the dorsiflexors to be active throughout most of swing phase, even just a little bit after heel strike. So if you cannot dorsiflex the foot, you're going to have a problem dragging that foot along the ground when you're trying to swing it forward. And that could cause someone to trip. And it also causes an incomplete heel strike because you cannot dorsiflex in order to get that heel down. So you're going to land the ball of your foot first and not your heel. And that can cause some awkward gait patterns as well. But these people learn to deal with it because they learn that if they flex their thigh, they can keep their foot off the ground. They let gravity take over and swinging and really letting their flexing um, swing their foot forward, and then they just land on it perfectly fine. So it doesn't look too bad after a little while, but it does look a little bit awkward with the high stepping gait at first. Injury to the common peroneal nerve is actually the most common because it's so superficial on the lateral side of the leg. External pressure, such as plaster casts when you break your leg, lithotomy supporting, lotus position, which is a yoga position shown here. Again, the pressure is all on the lateral lower side of that leg, which is right where the peroneal nerve is. Strawberry picker's disease, again, if you're um, picking fruits and vegetables for a living, especially strawberries, which are low to the ground, you're going to be squatting all the time. You're going to put a lot of muscular pressure onto the peroneal nerve. And the deep peroneal nerve particularly is affected by anterior tibial compartment syndrome. So in that anterior compartment of the leg that we reviewed earlier, um, if you haven't used those muscles in a while and then you go out for a run, say spring comes along and it's nicer weather, and you want to go out for another 8-mile run that you used to do in the summer, you go out for your first one and you come back and you realize that your leg is going numb and it's swelling and it's hurting a lot, and it's particularly red. That's because those muscles are way too overused and worn out, and it can cause compartment syndrome, which causes increased pressure in the compartment and it can't be released, and that could compress your deep peroneal nerve. So if you have compartment syndrome where they haven't used those muscles in a while and suddenly they go and work them out and they have symptoms, look out for this high stepping gait as well in the initiation of compartment syndrome. Okay, so thank you so much for sticking with me. It's really late. It's about 4 a.m. and I have a cough, so I apologize that I'm a little bit raspy. But I'm going to leave you with this scary slide, pun intended. It kind of represents, or maybe doesn't represent, your journey in regional human anatomy. Maybe it was a rough road, but in the end, you know, you're glad you went down, and you're in a better place on solid ground, having completed the course. And sincerely, congratulations. It is an accomplishment to be finished with this course. Just think of where you guys came from, you know, what you knew at the beginning of the course, and now what you know and what you can take forward in your respective careers. And lastly, I just want to say thank you all so much for putting up with me and for all the positive feedback that I've received. I do really enjoy teaching, and I hope to incorporate it into my future career. So thank you for being a part of my journey equally as I was or wasn't for yours. So thank you all, and best of luck in this last week of Regional Human Anatomy.